I'm Robi William. I'm an MD second year student. May I know your name and your age, please?
My name is Rishi. My age is 16.
Is there any problem did you come here today?
No.
No. Do you have any cough or breathing problem?
No.
Do you have any wheezing problems?
No.
Okay. Today I'm going to examine your lungs, and it will be a little bit uncomfortable for you. I will be palpating your body. Is that okay for you?
Okay.
Okay. I am making sure the patient's concern before the examination, and I am preparing for an examination that is effective and protective. If the patient is a smoker, I will counsel the patient about the risk of the related diseases and death. Do you smoke? Okay. Today we are going to do a lung examination on you. For that, I would ask you to remove your t-shirt. Is that okay for you?
Okay.
Okay. I am preparing for the examination by cleaning my hands and keeping in mind the patient's health history. I'm beginning the examination of the chest with a brief survey of the patient's thorax and respiration. I am noting the shape of the chest and how it is moving. I am checking whether it is symmetrical or is there any bony deformities. I am observing the rate, rhythm, depth and effort of breathing. I am also listening for any audible sounds of breathing that may indicate respiratory distress. I am listening the number of breaths per minute. The patient is breathing easily and quietly about 16 times a minute. The safe limit is 14 to 20 times a minute. I am listening the patient's neck for any retraction of the accessory muscle, noting mainly the scalene muscles, sternocleidomastoid muscles, supraclavicular muscles. I am palpating the trachea to ensure it's in the midline. I am checking the patient's color for circummural and nail bed cyanosis, that is, the bluish color arising from the deoxygenation. Now I am examining the posterior thorax beginning with inspection. I am observing for contour, symmetry and deformities and also inspecting the overlying skin. I am palpating the chest wall to locate any areas of pain or lesions or tenderness or bruises or suspicious root fractures. I am checking for patient's chest expansion by placing my hands close to the spine on the level of the 10th rib. I am asking the patient to breathe in deeply and fully, while I will be checking my divergence of my thumbs. Decreased excursion suggests restrictive lung disease. I am systematically palpating for tactile fremitus. Rishi, now I will be touching your back, and you should repeat the words 99 continuously. Is it okay for you?
Okay, sure.
Okay, like 99, 99, 99. Okay?
Okay.
Okay. Now,
99. 99. 99.
I am feeling for the vibration of tactile fremitus as the patient keeps repeating 99. I am using the ball of my hand to identify the areas of increased, decreased, or absent fremitus. I am palpating and comparing the symmetric areas of the lungs and identify and locate any areas of increased, decreased, or absent fremitus. Now you can stop saying 99.
Okay.
I'm continuing the examination by percussing the chest in a systematic manner, moving down the thorax and going down from side to side. I am listening to the intensity, pitch, and duration of my percussion, notes, and noting the sense of vibration. I am identifying the types of sounds that I am hearing. Normally, the sounds are resonant. Hyperresonance suggests COPD from alveolar air trapping and delayed expiration. Asking the patient to breathe out and using percussion to identify the lower level of the diaphragm, measuring the descent of the diaphragm, percussing downward from the initial level of the diaphragm until I reach the dullness from the duller structures below. Excursion is usually 3 to 5 centimeters. Auscultation is the most important examination technique to assess airflow. I am beginning my auscultation by starting from the apices and proceed downwards, moving systematically from side to side in a ladder pattern and comparing breath sounds in symmetrical areas. I am listening to the duration, pitch, and intensity of the inspirating and expirating sounds. I am listening to the entire breathing cycle in one location. Vesicular sounds. Vesicular sounds are normal sounds, are soft and well pitched. They are normally heard during inspiration and during the first third of the expiration and can be heard over most of the lung fields. Bronchial sounds. Bronchial breath sounds are harsher, louder, and higher in pitch than vascular sounds. They are often heard over the trachea and main stem bronchi. The expiratory sound lasts longer than the inspiratory sound. A silent gap may separate these two sounds in bronchial breath sounds. Bronchovesicular sounds are often heard in the first and second interspaces anteriorly and between the scapulae posteriorly. They have an intermediate pitch and intensity. Adventitious sounds or added sounds can be heard in the diagnosis of cardiac and pulmonary condition. These sounds may include crackles, sometimes called rovels, or wheezes and rhonchi. Crackles are non-musical and brief like dots in time. They are often heard in pneumonia, pulmonary fibrosis, and early heart failure. Fine crackles are soft, high-pitched, and very brief and often accompany congestive heart failure. Coarse crackles are louder, lower pitched, and longer. Compared to crackles, wheezes and rhonchi last much longer and sound more musical. Wheezes are relatively high pitched and have a hissing or shrill quality and often suggest asthma. Rhonchi have a lower pitched snoring quality and arise from secretions in large airways as seen in bronchitis. If I hear abnormally located bronchovesicular or bronchial breath sounds, assess transmitted voice sounds while osculating the chest again, asking the patient to say 99. Can you say 99 continuously?
Yes.
Okay.
99, 99.
Larger sounds that reflect transmission through airless tissue are called bronchophony. Testing for egophony of E2A changes which occur in low bar consolidation from pneumonia. Can you continuously say
Okay.
E,
Okay.
okay? Say.
E, E, E.
I am hearing a muffled long E sound, but if the underlying tissue is consolidated, the E sound changes to a bleeding A quality. Can you whisper 1, 2, 3 like 1, 2, 3?
Okay.
Okay?
Okay.
Start.
1, 2, 3.
Finally, checking for whispered pectoriloquy by asking the patient to whisper 1, 2, 3. Clearer and louder sounds suggest underlying consolidation. I am having the patient to lie supine to examine the throat and ask them to breathe normally and observing the condition of the skin and inspecting the chest for deformities, asymmetry, and respiratory movement. Palpating the chest to locate any areas of tenderness or to assess the lesions or abnormalities. I am also assessing the chest expansion. I am placing the thumb along each costal margin with my hands along the lateral rib cage. I am asking the patient to take a deep breath. Can you take a deep breath for me? Deep breath. I am observing how far the thumbs diverge as the thorax expands and feeling for the extent and symmetry of respiratory movement. I am palpating for tactile firmness. I am comparing both sides of the chest using the bell of the hand. I am percussing the anterior chest and the lateral chest. I am percussing in progressive steps downward in the right mid-clavicular line. I am identifying the upper border of the liver dullness. Asking the patient to breathe with the mouth open and somewhat more deeply than normal for auscultation. I am using the ladder pattern to compare both sides. I am listening to the breath sounds, noting their intensity and identifying any variation in normal vesicular breathing. Can you say 99 for me repeatedly?
Okay. 99, 99, 99.
Your lung examination is now complete. Thank you so much for your time.
Okay.
Thank you.
Thank you.
Today, I examined Rishi, a 16-year-old male. On general examination, he was normal and there was no shortness of breath. I completed all the assessments and it was all regular. It was a normal lung examination. Thank you.